check and make sure this works. There's always a lag. So going to say, hi, everybody, and welcome to the, I guess the second live video. I was going to say workout, the second live video for discussing hormones, hormone therapy, GLPs, and peptides. And for everybody that was on here last time, it was in the Facebook group. We uploaded into my YouTube page, and it's just been so good in terms of everyone has been just so, there's just a lot of questions on this, right? So we want to make sure that everyone gets to be a part of this. And that's why we're going to keep doing it. And we're just going to keep answering questions that everybody has. So let me click this out of here, go to here, and then I'm going to introduce you guys to two people who are just mean the world to me. Two guys that have been around for a very long time in my life. And so some of y'all already know Matt Sexton. And then the other guy, and Matt Sexton is the practice director and the co-owner of Oral RX. He's the big muscly guy right there. It also says Matt Sexton on there. And then introducing the second part of Oral RX is Dr. Kent. He's a medical doctor, and Kent, I'm going to let you tell them how you're not just a medical doctor. There's a lot more to it than just that. So tell them a little bit about you and whatnot as I get this all going.
All right. Thanks, Joel. So I am a board certified general surgeon and was trained in my residency after completing an osteopathic training in medical school. In the States, there's kind of two different ways to go through medical school. You can either go through the allopathic, which is the traditional MD, or you can go through the osteopathic, which is the doctor of osteopathic medicine. That's kind of a, let me mute that. It's kind of a misunderstood field in some ways. A lot of people, I mean, when you see me on the street and see me in my operating room, I'm a surgeon and a physician just like anybody else. But the philosophy through school and the training through school is a little bit different between an osteopath and an allopath. So as I approached getting into medical school 20 years ago, I looked for something that was more consistent with my worldview and my approach to health, which was treating the whole patient, working at it from a situation of restoring a person back to health through utilizing what they already have in them, whether that would be through manual medicine, which is a major focus for osteopathic medicine, or just approaching body systems from a rebalancing standpoint, as opposed to a lot of the allopathic or MD training is more focused on disease specific. Here's the disease, here's the management, here's the pathology, here's the treatment, and you just keep kind of moving down the line that way. So that's what I do, and that kind of has dovetailed into a lot of different things for what I do professionally now as a general surgeon and how I focus my career. And that's also led me to Oral RX, because it allows me to not just serve the local community that I live in, but to take what we've been working on from a health standpoint and actually taking it national. So it's been a pretty exciting journey for us.
Yeah, it's been a lot of fun, and you know, I've been part of a lot of the conversations as this has been coming off the ground and has gotten off the ground, and it's continuing to pick up steam, and it's awesome. And so, you know, with that, we'll jump right into this. So, you know, a couple of weeks ago with Matt was here at the house, and we did this initial conversation and discussion with everybody. And you know, I think the biggest thing is right now wanting to give people the information. And that's where it really comes down to, is understanding that what we do, the three of us here, is understanding, helping people understand that, you know, you got to get the information and to make a educated decision versus just saying, hey, I'll take this, right? Or just ordering something from a company and start popping pills. So we don't want to do that, obviously. But what I do want to do is we're going to go down, and we're going to start like we did last time, Matt. We're going to talk about hormones. We're going to talk about GLPs, and we're going to talk about peptides, because, you know, like it just, you know, that way we can kind of keep it going. So, you know, one of the biggest things that I think that I want to address is in terms of hormones, because we know there's a lot of our audience are women, and there is a lot of misconceptions about what hormone therapy consists of when it comes to women. A lot of people, they just think it's estrogen. They just think that's what they need to do, when it's actually not estrogen, it's actually testosterone, right? And that it's like the T word that can scare people. So Matt, I'm going to start with you and want you to go through just, that initial process again, when someone calls you and says, hey, I have questions about hormone therapy. What do you say to them? Oh, I don't hear you. Wait. Time out. Is your big mic not working? Your big mic's not working. Yeah, we planned ahead and got microphones, and Matt says his is bigger than mine, but it's not working now. So I don't know. Just unplug it. Maybe. Don't hear you.
Still nothing. Okay.
There you are. Yeah, I hear you now.
Better.
We'll have a conversation about that later. Mics and the size they are. All right, so talk to everybody about how when you first start, specifically women. We'll talk about men in a second, but specifically women when it comes to hormones.
So first, it's all done digitally through email. So we'll get all their medical backgrounds, their paperwork. We'll get their consent forms done. If they have labs, we can use those as long as it's got all the hormones on there that we need. The big ones specifically are going to be your testosterone, estrogens, E1 and 2, E3, and the progesterone. Okay. We obviously would like to have your lipids and your full CBCs as well. But we could do without that in the beginning. If you don't have any of that, we use Quest Diagnostic. We will go ahead and run that for you. If you do not use a DHEA supplement, which will alter your testosterone test on there through Quest Diagnostic, it will only cost you about $204. Okay. If you do use a DHEA supplement and don't want to discontinue use before that lab work, it costs about $274. So there's no way around that. Okay. But that is the first step. We need to get those labs so we can see what's going on first with your hormones. And then from there, Dr. Bowden and I will do a full lab review. We'll make some recommendations and we'll email that back to you. At that point, you'll schedule call number 2 and we'll go over the recommendations. But again, step 1 is making sure we've got those labs. Labs are everything.
Right. And so with the labs, I was just talking to someone yesterday about this, is because they always say, can I go through my PCP for this? Like, why can't I go through my normal doctor and my PCP? Why can't they? Or why what happens?
Yep, that's a great question. So all labs have different standards. So they have different norms, they have different assays that they use for doing the testing, and they have different results. And what we're looking for on a lab profile or on a hormone panel may not necessarily be what your primary care physician would be interested in. So what we're interested in doing is treating your whole health. So we do want to do a complete health analysis and figure out if there's any other low-hanging fruit or other areas that you need to be concerned about. I do get asked every day if people can just forward the labs that they have from their physician, or, hey, I'm going in for my physical with my doc. Can I ask them to do that? And I tell them they can go ahead and ask for them to draw the panels, but it's not necessarily going to be helpful for us because it doesn't necessarily have the same values or the same ranges that we're looking for. But the other real big part of it is your primary care doctor or your health professional may not be interested in managing that, which is what brings a lot of people to us, because they get frustrated or they get exasperated, or they just feel like I'm not necessarily being heard, and I don't feel like my actual questions or my concerns are being addressed. Patients to us, which is another reason why we wanted to have a national presence as a telehealth company. It's also incredibly important to get labs because we are sending controlled substances. We're putting our licenses and our careers on the line to send a controlled substance to you, and we're not just going to shoot in the dark to do that. That's not right for our patients. That's not right for you and your total health.
Right. So that's the biggest thing, I think, where and Julie asked that, how would you advise getting the required blood work if your GP won't order them for you? Well, this is the next step. And I think that's what everyone needs to understand is, like we all have, if you have insurance, you have a PCP. I have a PCP. I just got my labs done for my annual physical less than a month ago, just a couple of weeks ago. And, I sent those labs to you guys, and you look at them and like, it doesn't test any of this stuff. So, and you can specifically ask for it, but there's going to be a lot of doctors that even if they do test for it, they'll look at those because the ranges are so high and they go, oh, you're normal. So, it doesn't.
That's actually a big thing.
What's
Your
that?
basic labs that you're going to get from your healthcare professional is going to be to check your blood count to make sure that you're not anemic or harboring some sort of a bloodborne cancer. It's going to check your liver function to make sure that you're not going into any liver or kidney failure. It's going to check your basic electrolytes and your cholesterol levels, and that's it. If they do check a hormone level, they're going to use it as a reference range. But keep in mind that when you're looking at progesterone or estrogen in a woman, or even their luteinizing hormone, those are ones that are completely fluctuating on a 28-day cycle all the time, depending on where you are in your age range. And for testosterone on guys, the range can be anywhere from 200 to 1800, which is an enormous range. So as long as you fall inside of a normal range, they're just going to check it off and say that it's a normal thing, even if you don't feel normal.
Right. And so, Matt, you look at those. I mean, you're looking at this stuff every single day, and you're talking to people who are saying they don't feel right. They just don't feel themselves. And I was one of those people a year and a half ago.
Oh yeah.
Right? I said, I was like, dude, I just don't. I'm like, I'm still working out. I'm still eating right. I'm like, I don't feel right. I'm like, it's not the same as it used to be. And for the most part, most doctors, and we were joking about it, like, welcome to your 40s, right? But that's what a lot of doctors just say. Welcome to your 40s. This is how it's going to be, and they say that to women as well. So I mean, you see it every day, right?
Every day. A big thing is making those small tweaks, really. Like your doctor looks at it and says, oh, you're 200-300, but you still feel horrible. So for a female, our goal is to get you up to somewhere between 100 and 200. For a guy, between 800 to 1,000.
Yeah.
And
I'm batting 1,000 now, and like I feel amazing. Like it's just, and we maintain that, right? You still get it checked and everything like that. So obviously there's a lot of questions as we're getting into that 40, 50, 60-year-old range. With women, we start talking about premenopause, perimenopause, postmenopause, all those things. So, how do you guys tackle that? Kent, let's start with you on that.
Yeah. In those age ranges, at that point, you basically stopped making your estrogen. Your progesterone is going to trail off to an incredibly low number. And that's where bone loss starts coming in, and the other postmenopausal changes where you're going to struggle with weight, you're going to struggle with energy, you're going to struggle with libido. In those situations, honestly, if we put you on a low dose progesterone and some testosterone, you're going to increase your strength. Your bone loss is going to stop. One of the things that's important to understand about bone loss is when you strain against a bone by using a muscle, it reacts by strengthening. And so that's part of the things that we do all the time, because everything that we're doing is to treat your total health. I'm very active. I exercise every day. Matt, he's exercising every day. And if you guys are only in here because you know about Joel and you know his background. It's that resistance training that puts the strain from the muscle to transmit into your bone that's going to help to stop that demineralization or that weakening, the osteoporosis that occurs really a lot in women. And if you're on some testosterone as a low dose, it's going to give you the energy, it's going to give you the lean muscle mass, it's going to help to halt or slow osteoporosis. And then if we put you on some progesterone, you're going to continue to feel more balanced and more like yourself.
Matt, Bree, your wife was going through a lot of that with testosterone, right? She wasn't feeling herself, and then this was like earlier last year, and went through that whole process and started taking, and she's rocking it.
Yeah, right she was having all the classic symptoms, low libido, fatigue, tiredness, low energy, not really the osteoporosis, because I think, for her, she's very fit and a little bit too young for that right now. But even a bit like of the thinning hair and things like that, the mood changes, not hot sweat flashes, but a little bit of trouble sleeping at night. So for her, getting on that testosterone and really boosting all that back up, and because she works out so much, regaining that ability to see those results in the gym, because women put a lot of work into it. And honestly, women drive the fitness industry. So for them to go to the gym day after day after day and not get results is very disheartening. So the testosterone really changed the game for her.
And Kent, Becky did the same, didn't she?
Mm-hmm. Yeah, she's been on it for about a year as well, and it has been a life changer for her. She has way more energy in the gym. We're both in our mid 40s, and so we're going through all the stuff that mid 40s goes through. And so it's been a real beneficial thing for both of us. And that's another thing too. There's a lot of advantage to having, if you're with a partner, if you're both doing it, if you're both on it, because you're both going to benefit from it. You're going to have the same energy. You're going to have matched energy. You're not going to have one of you's, go, we can do this, I can handle this. And the other one's kind of dragging because they just haven't caught up to where you are. So I think it's a real good thing. And I think if you guys hang with us, we're going to run some specials that are going to come after the beginning of the year that are going to really target our couples, because it's really important, I think, for people to approach to share common goals. I mean, you wouldn't be with the person you're with if you didn't share common goals.
Yeah. And when one person feels better, you want your partner to feel better as well.
100%.
I mean, that goes on. So that's what the menopause and all the different ages. There were two different people asked in terms of questions about when it comes to taking hormone replacement therapy and being like on birth control or anything else that might throw their estrogen off, because I assume that would be thrown off, right? Even when you do your panels.
You need to reveal what you're on, because there's a host of different types of birth controls that are out there. There's progesterone only pills, which basically they work hormonally to allow your body to think that you're still pregnant. That's what the progesterone hormone is. It's the hormone that retains your pregnancy. You can do mixed ones, which will do a cycle throughout the month and then basically just cuts it off at the end of the month so that you shed the endometrium and end up having your cycle. So it would depend on which one you're on. We'll collect that information from you. That gets counted into the labs. But your testosterone itself, you would have to be treated. We'll get into the weeds real quickly for biochemistry. The biochemistry.
Not a lot of weeds, Ken. We could be here all day. Not a lot of weeds.
Real quick. The base hormones between estrogen and testosterone are very, very similar, and they can convert back and forth in your body through the action of an enzyme that's called aromatase. And so when you have a bodybuilder who is overdosing or super therapeutic on their testosterone, they actually convert into estrogen and start to have the secondary sex characteristics that come from estrogen. So those are the things. Yes. Yep. The gynecomastia, the big boobs. So those are the things that we're going to go through with you. We're going to work with people to find their goals and to help them reach their goals. And we need to know about those things that you're on in the background. But being on a low dose testosterone is not going to increase or decrease necessarily the efficacy of your birth control pills if you're on them.
Right. So because of that, and then someone mentioned IUD, asking if that was, if that had any bearing on this. And so, but all this stuff goes into, it's like, well, that's why they talk to you guys. Just same thing. You disclose everything before you go through the process, right?
That's actually really important. Not telling us if you have an IUD or birth control, it will throw your labs off. Right. So that will change our recommendation.
Yeah.
Well,
so
and that's also a pivot, because if you're taking a GLP-1, what they have seen across the country is there's an increase in pregnancies on people who are on GLP-1s because there are some issues. So those are the weight loss medications. And so that's an important one to know as well. So
I just thought that would be because they were feeling better. So that meant they were getting busier.
That is a part of it as well.
Yeah. It's like, hey, you feel better about yourself, you're gonna, it's gonna lead to other things. But that's important to know. You got to know if anything you're taking is having an issue with your birth control. Last thing on hormones, because this was actually asked 2 to 3 people asked this in terms of HRT and cancer risks. Obviously, and Matt, you've mentioned this before. I mean, this is why y'all have to disclose everything has to be disclosed. You have to know everything. You guys know, for instance, everything about my health history, my background, my everything in my family. As you guys know, my family has cardiac issues. So it's like, this is why it's important to know everything, right? Because it's like, so HRT doesn't necessarily, like you're saying, cause cancer, but if you have specific markers that are of concern, right, then that's something you got to look at.
Yep. That's again why there are sources where you can just get replacement medications or replacement therapy. There are doc in a box places similar to, 10 years ago in Michigan, when they legalized marijuana, you could go into a motel, meet somebody for 2 seconds and get a prescription for your medical marijuana. So
Right.
that is just the stuff that's out there. There are people who will indiscriminately give you what you think you want or what you think you need. We don't do that. We are not going to put you into a level that's going to put you at risk. Keep in mind, when we're talking about getting you optimized with your hormones, we're not taking you up to a testosterone level, and we're not going to encourage you to go to a testosterone level of 3,200 or 3,500 for a guy. We're going to get you around 1,000, which is also still within the normal range. It's at the high normal range. And we're not going to make those recommendations if you have, as a guy, specific risk factors, like you have a elevated PSA and you haven't had that checked to make sure that you don't have any type of prostate cancer. But what we're doing is we're supplementing what your body naturally has, and we're just upregulating you to a place where you're now optimized with what your body is normally producing.
Yeah. So, and speaking of, and obviously if it's not producing things, then this is why you want to look into taking things, because it's not producing. So, so Matt, and with that, because there's always the question like, well, if I start taking HRT, do I have to take it for the rest of my life?
That's a great question. The answer is no. You don't have to take it the rest of your life.
I don't know
let's
why
say your testosterone is 200 and you get on HRT, and a few years down the road, you decide, hey, this isn't for me anymore. All that's going to happen is you're going to go back down to that 200. Or if you're an older male, every year the testosterone is going to drop just further, right? So you might go down to 150. The worst thing about coming off testosterone is when you get on it is if you decide to come off, is that drop back down. So for me, I'm at 1,500. I'm 6'2", 250 pounds. So I need to be a bit higher.
Mm-hmm.
That's just where my body operates. So if I was to drop back down to 600, that journey back down wouldn't feel so great.
Yeah.
That'd probably be the worst thing, is just going back down to that, And then also I would probably want to do a PCT. I'd probably want to get on a gonadotropin or an HCG or something like that, or an enclomiphene or something to stabilize and turn everything back on testicle wise, get my FSH, my LH turned back on.
Right. So and that goes with women too. It's not just men. It's like you can stop taking this stuff, but is it safe to assume that you are going to go back to feeling the way you were before you started, or possibly worse, because you're going back to where you started and you've aged since then, right?
Right. You went on it for a reason, and you've aged since then.
What's that?
Mm-hmm.
You went on it for a reason.
Go ahead.
Which one?
Yeah.
You went on it for a reason, and you've aged since then. So when you come off, you won't necessarily go back to where you were. You'll go to where you would have been naturally at that age.
Right. Which is, and Matt, is that what you're going to say?
Yes. And with the caveat of there's also going to be suppression too, because you are basically putting your boys to sleep. So you're suppressing the testosterone because you're putting it in now.
Right.
So obviously if you come off, you have suppressed it. So even if you don't use any kind of post-cycle-therapy, for lack of a better term, basically because you're not using testosterone anymore, you would have to wait for your body to start producing again. And that could take some time depending on how old you are.
And it's just, it's a crazy, and I understand that because I had these exact same questions to you guys before I started taking testosterone, right? Which again, I'm on a low dose. And I bat 1,000 a month, not a month, but I bat 1,000 now on my levels. But I had those same questions. But now being on it, I can truly understand that feeling of like, why would I want to go back to feeling like shit? That really is what it comes down to. And that's what, and I say that very bluntly, because that's what people are feeling like right now. There's so many people, and you see them when they're just walking around. I was walking around the store last night with my girls. I was looking at people and they just don't look. Well, I know it's the holidays and people are stressed, but but people just don't look like they feel good. And I know that a lot of it, I'm not saying this is the only reason, but I'm saying there's just a lot of ways you could feel better. And I really just want people to do that. So last question on this, with hormones, and we'll jump into GLPs. You don't have to inject it, right? There's options, right, Matt? Tell me the options, because some people are scared to death of needles. I self-inject, you guys self-inject. It's not that big of a deal. It's, like they're little, well, depends on the needle, but there's other options, right? We're not tied to needles.
There is. Currently you're looking at 3 options. You've got injections, obviously, which we use a 28 or 29 inch gauge syringe, insulin syringe. So it's going to be small. It's going to be larger than Yeah, it's and the thickness is going to be, strand of hair, maybe a little bit larger depending on your strand of hair, right?
Yeah.
After that, you've got your creams, which I'm not the biggest fan of. Creams are 1 to 2 applications once or twice a day. And for guys, they're going to go underneath your testicles, and you got to stand in the bathroom doing that Captain's Morgan pose, put up on the toilet, waiting for it to dry. You can't have intercourse, because you don't want, while it's still wet, you got to wait for it to dry. Otherwise, you could risk rubbing that all over your partner. And if your partner doesn't want testosterone, that's not great either. Okay. Option number 3 would be the sublinguals. You have ODTs, oral disintegrating tablets, and you have troches, which are usually mixed with MCT oil, coconut oil. Just put it, in your mouth, in between your lip, underneath your tongue, let it dissolve. Problem with that is, yeah, it's sublingual. You are going to avoid first pass of the liver with both of them, but eventually everything does go through the liver. So for us, we always recommend the injections first. If you're just needle squeamish, or if that's just not your thing, definitely the cream is going to be the best second because the absorption of the skin. And then third, I would go with the troches or the ODTs.
Yeah. So injection's the best. And you guys, I'm going to tell you right now, if you haven't ever done it, it's really not that bad. Yeah. It really isn't. You get used
You've got
to it.
options on injections too. I mean, you can use your glutes, you can use your thighs, you can use your shoulders. Don't recommend that unless you're a bodybuilder. You can do them sublingual. You can do them intramuscular, which is, in my opinion, the best for absorption. Historically, everyone's going to say you get the best absorption either way, sub-Q or IM.
Yeah.
The problem now, and this is really for the women, the problem with sub-Q injections is it can leave a lump. Okay. So, if it's summertime and you're thinking about, hey, I'm going to go to the beach, I'm going to wear a bikini, I'm going to look sexy. Now I've got this little injection lump that I didn't rub flat. Right. Probably not the greatest, right?
So in that instance, your partner comes in to rub.
Yeah. Have someone rub it for you, but just make sure you're going IM on that point. Really get that syringe all the way in there. Otherwise, it will be sub-Q. Now, if you're a person that has a little more dump in your trunk, you got a little bit of fat back there, it's not going to be IM. These are insulin syringes. Even though they're long enough with 2029 to get into the meat, it still might not. So in that case, you may need to find a place with lower fat to make sure it's IM.
Yeah. So all this stuff is what you guys teach your clients. Yes. People. I mean, like that. So just understand, everybody who's watching, this is not like you don't have to take notes on this and say, okay, I need to do sub-Q. I need to do this. I need to do that. You don't have to know any of this stuff. That's their job, is to know all this stuff. We'll coach you based on what you need on that one. So that's what that comes down to. We'll
even send you pictures.
And it shouldn't be. It shouldn't be daunting. It's not a large volume. When we send it to you, we will send you a 2 or 3 ml vial. So it's not even an ounce. And that is a 1 month supply, which means you're drawing up on the order of drops. Yeah. Yeah. These are very small. Everything is in very small dosages, everybody. So it's something, again, It's not daunting, but I'll tell you this and we'll move on, it is a lot easier to do this when you start feeling as good as you do. And when you start feeling better and you know that that's the reason for it, then you look forward to it. You're like, okay, let's go. Like it just becomes second nature. It really does. And that's honestly how it's become for me. This is 100% second nature. So, all right. So hormones done. There you go. There's your little needle. See, look at it.
Yeah. I don't know if you guys can see it. It's teeny.
Yeah.
It's very, very small.
It is.
So the largest numbers on here, that's going to be the units. That's how we're going to talk to all our patients in units. We've done the math for you guys already. So you don't have to stand in the bathroom with your butt out trying to do math. Okay. That's our job. We're going to take care of that for you. On the bottles, it will be dosed out. You'll have directions. It's very simple. If you don't understand it, just email us. We'll explain it again. But again, it does come with pictures. Yeah. How to use it, how to read this. Okay. So don't be scared of these. Very, very simple.
Yeah. Even if you have to reconstitute it, which is mixing it yourself, which some compounds, testosterone, you don't, but some of the compounds, like when we go into peptides, you do. But again, Oro team talks you through everything. So speaking of talking through everything, hot topic, GLPs, still going. It's not going away anytime soon. I mean, I know there's conversations going right now about pulling, where the FDA is trying to pull emergency authorization on them right now, Kent.
Yeah.
But let's be honest, they're not going anywhere.
When you talk about pharma and pharmaceuticals, it's a very interesting. That right there is a whole series of podcasts in and of itself.
Right.
There, there's
okay. So let's just talk about it from a standpoint that people are interested on it. They help. They work. They help people lose weight, right? There's no question about that. They do. But they are not step one in a process of trying to lose weight.
So I can speak directly to this. I come from a background or from a history where I was not at all a proponent of weight loss medications or weight loss surgeries. I am trained. I already said at the very beginning that I'm a board certified general surgeon, and I was trained in bariatric surgery. It was a very hot topic because it was really still on its upswing when I came out of my training program. And the hospitals that I interviewed with said, "Oh, hey, we'd love to have you set up a bariatric program." And I had no interest in it. And I still don't do bariatric surgery. I did it in my training because it was required, but I don't do it. I know that there are varied responses and success rates with Roux-en-Y gastric bypass, gastric sleeves, banding, all the different things that are out there. But I've been around it long enough to see that there is many, many people who have a check mark response where they lose all the weight and they feel fantastic, and then they turn around and they come right back up. And it ends up being like a lot of other fad diets. And the reason why there's so much, I mean, that's the whole healthcare, weight loss, fitness industry, is that if you're not doing the things that make you successful from all fronts, you're not going to have that success. So when the GLP-1s, which have honestly been around for a very long time, started to move to the forefront, I wasn't a big fan of that. But now, obviously, here I am in my practice selling it and promoting it. And the question would be, why am I doing that? And it's because the only way I would recommend it is as long as you are incorporating it into a total health plan, meaning you need to be working, you need to be exercising, and it is then a tool that you can use that will give you success. We have patients who have lost over 30 pounds in 6 to 8 weeks, which is a very rapid rate. We typically don't see that, but they've always been active. They just ended up needing that additional kick that the GLP-1 gives you, which is a naturally occurring hormone in your body that your stomach produces when it's full and stretched. So I am now a proponent of it, and I know that I've done a 180 on that, and I own that. But it's because it has to be a part of an entire regimen, and it has to be used with your being active and eating correctly. What it does is it makes you feel full, but you got to take your protein.
It's step 3, right? You have to work out first. You have to work out. You have to get your eating in check. And this is step 3 of the process. And Matt and I we talked about this last time. This is not like the GLPs. They do work. And I've told people before, and I'm like, I've tried it, right? Because I wanted to be able to know what it's about. And when I say I tried it, it's microdose, like, tiny, like 15 units a week, which is a very small amount. But I get it. I understand. Like, the feeling of it was just like, sometimes you just forget to eat. I'm like, which has never happened to me before. I've never forgotten to eat in my entire life. So I understand, and I wanted to do it so I could talk about it and say, okay, this is how I understand. So I really do see where it can help people. Now, I think it should come from 2 different sides of it. And let Matt take this one, of like where you have excess weight to lose. When I say excess, I consider excess, usually over 20 pounds, 15 to 20 pounds is considered excess in my book, because anything under that, you're, I don't want to say fluctuating 10 to 15 pounds, but it's a lot easier to lose 10 to 15 pounds, obviously, if you're into that excess range, right? And you need that help. So let's just say 25 plus pounds. So there's that side of it, but there's also the side where you have someone, Ken, as you said, they lost a lot of weight, but they also have the side where, like, people are looking to lose those last 10 to 15 pounds, right? And they've tried everything else. So Matt, talk about that, because I'm sure you've talked to people on both sides of that spectrum, right?
Every day. Yeah. So I'll use you as an example. Joel is not what we would consider a high calorie individual. He's obviously very fit, has a lot of fitness programs. Everybody loves him. We've all seen his abs. We've seen his shirtless pictures. So if Joel's trying to get ripped up for another program, or if he's just trying to look great at the beach that year and he just had a little extra fluff from too many whiskey wind days or, holidays, whatever, right? Joel would be somebody we would microdose with. We would probably use tirzepatide because that's right now the best you could get. And we would do 3 injections a week for him. It would be, like he said, 5 units. Monday, Wednesday, and Friday. We find that to be the best, most tolerable. Just goes right in your belly. Or honestly, you can go anywhere you can pinch some fat. Just anywhere you can pinch some skin at all. Slip it in there and you're good to go. That would be for somebody like Joel. Now, if you are more of a high-calorie individual, then you're probably looking at more of a half to microdose because we need to get more in you, right? So you're looking at Monday, Thursday, 10 units, for example, Monday, 15 units, for example, on Thursday. That'll push you through the weekend as well, and you'll get that gastric slowing. You'll get that appetite suppression. That'll give you 25 units for the week, which is more of a extreme weight loss, right? Not like somebody like Joel here or even Dr. Bowden, who almost has none to lose, just wants to look a certain way. So going back to a person that's got more fat on them, they're going to want to go with that. Now, if that starts to become ineffective after a while, because these GLP-1s, they do become ineffective because you build a tolerance. That's why the microdosing works so well. But when that happens, we can move you up, okay? We don't generally like to do that without a couple months of use because you don't want to lose the fat too fast, okay? You don't want that saggy skin. So you really want to let the drugs do their job, let it kick in, let your body get used to it, start losing the fat that way. So after a few weeks of use, don't just email us, call us like, hey, I've only lost 2 pounds. Well, yeah, I know we're doing this safely and medically. So let it do its job, let it work. Okay. Now, about 3 months down the road, if you're still a high calorie individual and maybe you're using it more of a crutch than you should be because you're not fasting, your exercise isn't that great. Maybe you're taking too many breaks during Joel's Lift 4s, something like that. At that point, we can bump you up with Dr. Bowden's approval, obviously, to more of a 50 unit. So now you're looking at 25 Monday, 25 Thursday. That is a lot, okay? But that would be, a different conversation for later down the road. We would do that. We can also offer you guys what we call oral gold, which is what we prefer to do with the low microdosing at 25. We'd add in peptides like tesofensine and 5-amino-1-MQ. Now you're going to attack that fat from 3 different angles, 3 different mechanisms of action. They all do the same thing. You're all looking at fat loss. It's just, it's an art and a science. We're looking at the person. Are you a Joel and a Dr. Bowden, somebody like myself? Or are you somebody who is got that weight to lose, need some motivation? You need to do a lot of Lift 4. You need to talk to us and really get it honed in. Then you're looking at a little bit more. But we do have all kinds of packages, and we can tailor to everyone.
And this goes in also. So, if you have someone, specifically a female, that comes into this and they go through their testing and they have, their testosterone is low, and then okay, we're going to go through that process, and then but you're not going to just say, okay, you just need a GLP to lose weight, right? This is, again, that's that whole, and you're talking about the oral gold package, right? And that's what that is. Yep. It's that holistic, the whole thing, looking at it, because that's when it works. Right? That's when everything works here, is when you get every cylinder firing at the exact same time, the way it should be. Right, Ken?
Well, and I do want to touch on that because everybody's following TikTok. We're all watching Reels, and you're seeing people who are out there who are saying that, when you go on a GLP-1, you should never come off of it. I'm not going to say that I ascribe to that, because if you've met the goal that you wanted and you're feeling better about yourself and you did it the right way and you got that weight loss and got active and ate right and exercised, and you get to the point where you're ready to start coming off of that, we can throw you on HRT, which is going to give you your testosterone that's going to keep that drive and that desire for you to maintain the muscle mass that you gained during that time that you were losing the weight. And it's going to give you the energy and to continue to assert yourself to those workouts that you started when you worked appropriately through the program that we're working on. We're going to work with you wherever you are in order to help you get there as safely as possible.
And that's a big deal. Sorry, Matt.
I do want to add to that real quick. What Dr. Bowden is talking about, guys, is for everybody watching this right now, when he's talking about HRT first, that really is the best option. You always want to have optimized hormones before you jump on medical weight loss. And the reason for that is, think about your body like a car. You're driving down the highway, you got 3 tires on the car, and your engine's on fire. That would be not having optimized hormones. Now you're trying to take those GLPs, lose the weight, but your car's busted, right? So fix the engine, get that fourth tire, get the car in good, optimal working condition first. Now that you've got that, add in the GLPs, the medical weight loss. Now you're cooking with gas. Now your body's really going to cook through that fat. Okay, it's going to use a lot more for energy because it doesn't have to try to worry about these hormones not working correctly.
Right.
Okay?
And I'm glad you said that. And I'm liking this new little stream platform we have, because now I can pop questions right up when people ask them. Can you guys see that?
Yeah.
So that exactly just ties in. Like, so what do you say to that, Kent?
I would say to that question, no, I don't have a certain BMI that I would qualify you in. We want to talk to you about what your goals are, where you've been, like what have you tried so far and not been successful at. That's part of the whole conversation in the counseling. I mean, we're taking this as medical professionals. We are not an online platform where you type in, I want this, and it just shows up at your door. It's not Amazon. This is healthcare. So if you want to do that, I don't recommend it. I would never support something like that, because you're going to get the Amazon outcome. If you want to take your health seriously, we're the place that's going to do it for you. We're going to talk to you about where your BMI is, where your goals are. Let's keep in mind, BMI is very effective, but Arnold Schwarzenegger at the peak of his career had a BMI of 45. He was morbidly obese according to the scale.
Yeah.
Yeah.
I'm overweight.
Same.
According to the BMI. So that's why I asked you, because I wanted to, because you're in that medical world, right? So that's what the medical world still goes off of, which is,
right.
Which is quite crazy.
But it's generally correct. So yeah. We'll work with you.
Yeah. The person that asked that last question, Erin. Hey, by the way, Erin's awesome. She's been with Oro for quite some time.
Oh, nice. Okay, cool. Yeah. So I got a question about hormones I'll bring up in a second, but I want to finish GLPs first, so then we can move on. So, lost my train of thought. So in terms of GLPs, I think that's the biggest thing, Kent, the point you just made. I want to make sure everybody heard that is watching this, is the fact that testosterone and GLPs you should not be able to just buy them over the counter. Right. So everybody understand it. Like, so, and this is not like, we don't bash products here. We don't bash companies, but you should not. And I'm going to say this because I'll say it, it's my thing. What you see on the commercials, y'all, of testosterone replacement therapy, or is going to boost your testosterone, or this is going to help you lose weight, is bullshit. All right. That is the straight answer to anybody's questions on that, and probably get some messages, but it's like, but for what I know and what I've seen and what I've read and what I've learned from these two and what I continue to see is that, just don't fall into that, because those are the two main things that we're talking about here, which is GLPs and testosterone. You can't buy it over the counter. You shouldn't be able to buy it over the counter. If you can, that means it's not going to work the way it should. So,
well, I'm in my mid 40s, so we can't go along this way without referencing Tommy Boy. As the late great Chris Farley said, you can get a good look at a T-bone by shoving your head up a bull's ass, or you could take the professional's word for it.
Yeah, and you actually got it right. It took him a long time to get that right in that movie too. He's like, no, it's your bull. Wait,
I mean, you can go to Thailand or Mexico and grab these things over the counter, but you're running a huge risk of putting something into your body that you may have to have surgery to have removed.
That's great. And Kent might be doing the surgery on you too. So last question about hormones before we move on to peptides. So what about those of us? So Wendy says cancer survivor and talking about HRT.
Well, we need to be more specific than cancer, because there's a lot of different types of cancers. There's bloodborne cancers, there's breast cancers, there's bone marrow cancers, there's colon cancers. So it would depend on what you had. I'm assuming in that type of a situation, she's talking about an estrogen receptor positive breast cancer. That would be, honestly, testosterone's not even a problem in that situation, because it's testosterone, it's not estrogen, and you're going to be microdosed. So it will not affect a estrogen specific receptor positive breast cancer. So again,
she did
consult with your specialists who are doing HRT as opposed to somebody who's not.
Yeah, there you go.
Yeah, be wary of those estrogen patches.
Yeah.
But,
So, all right. So Wendy, hopefully you're doing good with that. Cancer survivor. So congrats on that.
Yeah,
You said survivor,
exactly.
so.
I don't want to gloss over that. That's
Yeah,
an
that's
awesome
amazing.
thing,
And Wendy, you should be very
and that's
proud.
a fantastic problem to have.
Yeah. So, and that's where these guys come in. So, all right. Well, let's talk. Let's finish up tonight on the P word, peptides.
so,
Because
Matt,
I'm leaving.
Yeah. Okay. Let's all go. No, we're gonna go after this. Look, they are everywhere. They're trendy. They're the trend. I mean, if anything, they're actually more trendy, I think, than GLPs right now. You're seeing GLPs a lot of places, and you're seeing commercials for a lot. But I think we're going to start to see more peptides come in terms of companies and whatnot, because those are really easy to get, and they're very easy to say that, hey, this is a peptide. This is a peptide. This is a peptide, right? So that's kind of what we're getting into on this. So Kent, we'll start scientifically of what a peptide is.
Okay. How
Non-weedy though.
Non-weedy. Okay.
Short.
Think about meat. All right. The substrate of meat or the muscle that you're eating is a protein. Protein is a series of many amino acids that is just one long string of code that is then formed into a three-dimensional structure, and that makes the protein. If you were to take that long string of code and break it into sections, those sections are groups of amino acids, and those are peptides. Is that simple enough?
Yes, those are simple enough. So how is it that everything out there seemingly can be called a peptide?
Anything that is a derivative of a protein is peptide.
Perfect. There you go. Great. Man, you're like, I did not think you could be so succinct, and I'm so stinking proud of you right now.
We're done. I'll talk to you guys later.
That's awesome.
Out. It's over.
That was really good. So, okay. And the reason that we're bringing up peptides, because obviously you guys get the questions every day too, is there's a lot of companies out there selling peptides right now. This is not a group between the three of us nor a company with OraRx that we bash other companies or we bash other products. We simply show and educate people on the science of the products and how they're going to benefit you. So with that said, any other companies out there that have a peptide, and if you feel they're going to work for you, then go for it. If you trust that company, if you trust that person, if you trust the person who's selling them to you, if you have that trust established, then try them and give them a shot. There's absolutely nothing wrong with it, because I guess in the grand scheme of things, if the peptide doesn't work and however you're taking it, via orally or sublingually, I mean, you're pretty much just going to pee it out if your body doesn't need it, right?
Yeah.
There's a
I know I
reason
mentioned
why-
this last time. So your peptides, they have a job to do, right? Your body makes 7,000 different peptides. So if you're going to use a peptide, you need to figure out what you want to do with it and what its job is to do, right? Yeah. BPC 157 is a great example. BPC 157 is a healing peptide. It basically soft tissue, tendons, ligaments, and joints. I'm going to keep it real short at that. If you've got severe muscle soreness, small muscle tears, busted knees and elbows, BPC 157 is a great thing for that. That being said, that's its job. So a peptide that you're going to get from Dr. Bowden or our team here, it will have a job to do in your body. You're not going to just take some peptide off of a product that has an ingredient panel, which is probably an antioxidant. Okay. So like I said, they're designed to do something in the body specifically.
Yeah. So again, with that said, not talking about any other companies. We're simply talking about the peptides that we at OraRx go through. And when it comes to those, it's very specific to I don't want to say one thing in terms of one function, but it's a very limited scope, right? It's not just like, because like as you said, peptide is meant to do this one thing. So if you're taking, like you say, as you just said, BPC 157, glutathione, GHK, whatever those are, then they're specific to a very small amount of things that you're looking to do. So
It's sniper treatment as opposed to shotgun approach. If you're taking a peptide, air quotes, peptide that says that it's going to do a host of different things for you, then as Matt said it very simply, if you have to look at the ingredient panel, it's not, it may have peptides in it, but so does your flank steak. So
that sounds lovely.
You need to understand goal. We're doing goal-directed therapy. So if your goal is to decrease muscle soreness, we've got peptides for that. If your goal is to enhance collagen elasticity, we have peptides for that. If your goal is to get a better, deeper tan, we have peptides for that.
Yeah, there's really peptides for everything, and that's a good point, because then it's a, Matt will text me and he'd be like, dude, check this thing out. And it's like another peptide, and there's another peptide. I'm like, holy God, there's so many peptides. So that can be very daunting for people. So it's, the big question is like, how do they figure out what peptide they should take? Well, again, it comes back to their goals, right? What you just said, Kent, about that.
That's perfect. And I would recommend you talk to a professional. The person who's coming at you and recommending your peptide, what's their background? What's their training? Are they trying to just sell something, or are they trying to meet you where you are and solve a problem that you have?
So,
and what's their qualifications to do that?
Would it be safe to say you could divide these up? I'm making notes. You guys proud of me as I host this thing? Would it be safe to say you could divide peptides into 3 general categories in terms of beauty? Like the most popular peptides that are out there right now. So you have internal health, beauty, and then I say fitness, but from the standpoint, and I would almost put I know internal health and fitness can kind of go together. Maybe you guys can say it more better than I can, but of talking how, because the way I see it is okay, so you have peptides like IGF-1. Okay, so we know what that's going to do for for your muscularity, for recovery. BPC also goes into that soft tissue repair, but then you also have things like glutathione that is going to help you with your, with liver and immune system, right? So I feel like we could put those in 2 different categories if I'm not wrong.
I think a big way to kind of look at it is a lot of it is essentially anti-aging. We're trying to avoid or truncate the deleterious effects of aging. As we age, our cellular activity naturally goes down. As guys, our testosterone levels drop as we age. Our metabolism slows. Our clearance in our liver slows. And so we can go on glutathione to help with that. We can do methylene blue in order to clean up antioxidants and free radicals. We can do BPC 157, which we talk a lot about, and that's a very hot one, which now has an oral application. That is gastrin. That is a hormone, that is a peptide that is naturally secreted in your stomach to protect you from the battery acid that's in your stomach that digests food and keeps it from eating a hole in it, so you don't have a perforation that I have to take care of. So you naturally make BPC 157. And when we allow it to be injected and taken up systemically, it can give you the same healing that it does inside your stomach. You can heal from an ulcer in your stomach in 36 to 48 hours. I do a scope on somebody to take care of a bleed. I feed them within 3 days because it's healed. That's because of the gastrin. Then that's that healing peptide that we can have you inject closer to your trigger point where you have the pain, or now we also have it orally available so that it can get into a higher circulating volume. But just an orally administered one is going to have to pass through the liver, because that's the only way it gets to the rest of your body. And your liver is a big, huge filter that takes out anything it sees that doesn't need to be in there. And so
touch on that. Hold on. Let's stay in that real quick, because it's not, I think what's misconstrued is it's not the stomach where everything is going to get broken down and filtered out. Yes, it does happen in the stomach, but it's not the stomach where everything gets filtered out, correct?
Right.
It's the liver.
It's
So
it's going to be your liver. That's
if it
why.
makes it through the stomach, right? So Matt, if it makes it through the stomach, cool. Still got to go through the liver, right?
Right. That's why we recommend glutathione pretty much for everyone.
Yeah.
Glutathione is going to be your ultimate antioxidant. It's going to be your ultimate liver cleaning product. Think of it like that for layman's terms.
Yeah.
You know,
So
not getting weedy or sciencey on that one. It's gonna help your liver do its job more efficiently.
yeah. So to tell everybody, I started doing glutathione, the troches. So it's the sublingual. You just put it between your lip and your tongue, just because I didn't want another needle, basically. But it's also like I actually enjoy it too, because the troches, because again, in terms of efficacy, injection's still the best, right? You still, so you know, like for instance, if you do the injections, you can do it once a week versus the troches is every day, right? Because the efficacy changes. So I've been doing it, but I've been doing it now for just over a month. And that's why I haven't really talked about it much, because as I tell everybody, I want to try it for a while, but it is amazing. And I just was telling Kent and Matt, right? So I have my shots this morning, and they put you under with propofol. It's a low dose. You fall asleep, you wake up in 10, 15 minutes. This is the first time ever, like within a half hour to an hour, I feel like nothing happened. That was the weirdest thing. And then Kent was like, oh yeah, you're taking glutathione, right, Kent?
Yeah. Yeah. Well, and I kind of gave a little bit of a teaser about us trying to do some HRT targeted for couples coming up next year. Think February, maybe, you know?
Yep.
One of the other things that we're working on, again, with my background as a surgeon, is I want to have something that's going to augment and enhance people's recovery through surgery. So we are in the process of also developing a perioperative pack for people who are going to undergo sedation, have an invasive procedure, and need to recover quickly in order to get back to work, back to themselves, back to exercising, back to being a part of the family. And so we're going to take what we know about the things that are going to be best for tissue healing, metabolizing anesthesia, so you don't have that fog that goes through for several days. And that's going to become a package that we have available for patients. So
yeah, I am.
Stay tuned.
It's so crazy. Like the last time, so it was a year ago that, so, you know, RFN, radiofrequency neurotomy injections in my back for residual nerve damage. And last year I was down. I mean, I wasn't down from pain. I was down for the day, because I was just foggy, groggy for the rest of the day. And I hate general anesthesia because of that. But today, like I'm within, like I said, within an hour, I was like, can I go do something? What can I go do? It really is impressive with this stuff. So, all right, where are we at? 57 minutes. We're going to start wrapping it up, because I know it's a lot of information. I don't want to go over an hour, because I want people to be able to go back and watch this. So, what we've been talking about as the wrap up is ororx.com. That is the company. These are the two owners, Dr. Kent Bowden and Matt Sexton. And you know, we're going to keep doing this. Like we have no intention on stopping this. I mean, it's their company, but I love it too. I'm a part of it. We're going to be all together right after the holidays in Colorado skiing. So we're going to do, Matt's already got his board ready. So we're going to bring our BPC, and we're going to bring a laptop, and we're going to do a live. And we're going to talk about all this stuff again. But, you know, the biggest thing with everybody, you know, is just start the conversations. And you have to start the conversation. If you feel more comfortable, start the conversation with your PCP, right? If you have insurance, start that and have that conversation with them. And then, you know, if that doesn't get you to where you want to be, or you're not getting the answers that you want, then this is the next step, is to start talking to people who are looking to make you optimal. And I feel comfortable in saying that. I feel comfortable in pushing this company and this product and all these products, because we're not trying to sell you. They're not trying to sell you. I'm not trying to sell you a product. I'm trying to sell you a service to understand how this could better you. And that's what I hope everyone is understanding. This is like, it's not saying, hey, here's a pill, take these pills and you're going to feel better. I don't know what those pills are yet. They don't know what those pills are yet. But the more you talk to people to help you understand where you can feel your best, man, there's no replacing that. So final thoughts, Ken.
Well, I would exactly say what you said in terms of talking to your healthcare provider, but I will caution you, you may come away disappointed. So you also need to talk to those who love you, support you, and those and your partners, because this is something that no matter what we do, if we're out on an island, we won't have the success we're looking for. So find a team, find a group of people who will support you, and we can be those people. And we're going to help to equip you and give you the tools that you need to have the success you're looking for.
Yeah. Final thoughts, Matt?
Two things. One's testosterone. Look at the beards on these beautiful men, guys. I'm just saying, right? It works, okay? You know, it works for that too. DHT is an amazing thing.
My wife does not have a beard.
Lastly,
yes, hold on, wait, Matt. Ladies, you will not get a beard. Men, your beard might get a little thicker.
So the last thing, guys,
ladies will not get a beard. Don't scare them away.
Ladies, you won't get beards. I swear, we don't dose like that.
Yeah.
That's just a guy thing. So, lastly, though, we are starting to work with a lot more couples, a lot of married people. As we age, libidos tank. I think Joel touched on this in the beginning. In marriages or relationships, partnerships, whatever it is, you want to make sure that you guys are both on the same level libido-wise. Otherwise, things can get kind of wonky and it can cause issues. We do have specific sexual wellness products for this. They work for men and women. They're called Lucky Trookies. We have ones that work for both, and we have ones that are specific to either or. They both have oxytocin in them. That is one of my most favorite compounds. It's great for PTSD. It's the love hormone. It's great for anxiety, stress, relaxing. Man, if you're trying to get intimate with your partner, oxytocin is the way to go. It just makes everything better. Also, low-dose Cialis for guys and girls. Low-dose Cialis for guys, 5 milligrams. Lowers the blood pressure. Great for erections. You're not going to have an erection all day. Takes stimulation. But also shrinks your prostate if that's an issue, guys. Okay? So then we can put in there apomorphine. That's another ED medication, along with Cialis. And Somorelin, which is a growth hormone. Bet you didn't know that was supposed to go in ED medication, right?
There's a lot. There's a lot.
That's a lot. We got a lot of mad scientist stuff going on.
Matt will talk to you guys all night. What we'll do is we'll record Matt just listing everything out, and that could be your white noise while you sleep.
Matt's given a teaser of upcoming talks.
Of upcoming talks, yeah. So
Dictionary
we will do. I think actually we should do. And, maybe we can bring Ken if Beck wants to come on, or Bree or Megan comes on at one point. Obviously, we will bring the ladies on at one point. This is just, we're saying that really general high level, getting that basic information out. But then we can start, once the couple thing comes out, maybe after the new year, we'll start talking about that. I definitely want to touch on that, in the bedroom health, that libido health, because I know that is a big deal for men and women as they get older as well. And you don't want to lose that in a relationship. That sucks. So thank you guys. Thanks for everybody else joining on this one. ororx.com. Just fill the form out. I think there's a additional comment section, right, on that info tab. So if you're on, just put in, you're like, hey, listen to your podcast, or say, Joel, and you'll get bumped to the top of the list. So if you want, because I think
everybody's going to do that now.
There's a pretty extensive list right now, isn't there?
Hundreds of people a day.
Yeah, that's awesome. So, but if you guys listen to it, then say you listen to this podcast, and that will bump you to the top of the list, because obviously, we appreciate the time and appreciate the trust, and hopefully hope this was helpful. So thank you guys. I will see my boys in Colorado in a few weeks, and Merry Christmas to everybody else. So talk to you guys soon.
Everybody have a good night.
Thanks.
Later.